Hello, I'm Dr. John, and welcome back to Silver Serenity. If you are over 50, ignoring subtle stiffness is no longer an option, as delayed action could mean permanent, irreversible joint fusion and a total loss of mobility within the next year. However, understanding the early warning signs is your key defense, and today we will simplify these 4 critical red flags so you can take control immediately. Stay with me, because identifying just one of these 4 crucial indicators can be the difference between a life of independence and total reliance on others for basic movement. Before we proceed to the material, please share your city, age, and the specific health concerns you are currently facing in the comments below.
The creaking knee, the stiff, morning hands. These are often shrugged off as mere rites of passage in the elderly, a natural tax levied by time. Yet, this normalization is precisely what obscures the insidious progression of major chronic conditions. Osteoarthritis OA, particularly in the elderly population, is not simply wear and tear. It is a profound biological erosion that dramatically impacts the quality of life, often leading to severe mobility limitations and social isolation. The degradation of articular cartilage, coupled with underlying preclinical inflammation, initiates a vicious cycle of pain and functional decline. We often see patients who waited years, attributing their excruciating pain to simple aging, only to discover their joints have reached a catastrophic structural state. The failure to treat OA early relegates millions of older adults to needless suffering, transforming years that should be characterized by vitality into decades of dependency. In this discussion, we turn our attention to the highly nuanced world of inflammatory arthropathies, specifically elderly onset rheumatoid arthritis, EORA. Unlike the younger onset presentation, EORA often behaves atypically, masquerading as something less severe, frequently mimicking polymyalgia rheumatica. EORA patients may present with less overt polyarticular involvement and more prominent systemic symptoms, confusing clinicians accustomed to the typical symmetrical small joint disease. The pathogenesis differences are significant. PMR involves acute inflammation, usually targeting large joints and periarticular structures, while EORA retains the autoimmune signature of Ra, albeit sometimes dampened or shifted. Failing to differentiate these two leads to disastrous therapeutic choices. Misdiagnosing EORA as PMR means delaying highly effective disease, modifying anti-rheumatic drugs, allowing irreversible joint damage to proceed unchecked. A scenario akin to giving a patient with a raging forest fire a small garden hose and calling it treatment. Early diagnosis is the single most potent weapon against the long-term morbidity associated with these conditions. For both EORA and advanced OA, the therapeutic window is narrow. EORA. Timely initiation of DMARDs, and sometimes biologics, is paramount to prevent the radiographic progression that cripples function. Similarly, while OA management historically focused on pain relief, contemporary strategies recognize the need for proactive, multimodal management, including mechanical, pharmacological, and nutrigenomic interventions, as certain flavonoids show promise in preclinical models. The notion that an elderly patient must simply suck it up and live with the pain is medically archaic, bordering on malpractice. It is a common, though utterly frustrating, scene to watch patients proudly refuse help, stating, "My grandmother had pain, and she dealt with it." Yes, she did. And she probably spent her last decade confined to a chair, unable to tie her shoes. We are doctors, not cheerleaders for stoic suffering. The critical importance of early arthritis diagnosis in seniors cannot be overstated. It is a matter of shifting the narrative from passive acceptance of decline to active empowerment and management. Physicians must maintain a high index of suspicion, utilize advanced imaging and serological markers, and refuse to categorize debilitating joint pain as merely old age. Effective strategies, ranging from personalized exercise regimens to targeted pharmaceutical interventions, exist to manage both the pain and the underlying pathology of OA and DRA, significantly improving function and overall quality of life. Our mandate is clear: to ensure that the later decades of life are characterized not by confinement and chronic agony, but by retained independence and the fundamental dignity of mobility. The transition from generalized principle to specific clinical observation requires a sharp focus on the patient's initial presentation. The first signs that demand our clinical attention are rarely catastrophic. They are subtle. Nagging inconveniences often brushed aside. We must recognize these localized warning signs: the persistent ache that refuses to abate after a night's rest, the stiffness that makes turning a door handle feel like a monumental effort. In the context of older adults, this presentation demands high vigilance, while generalized fatigue or malaise often clouds the overall clinical picture. The specific triad of persistent pain, palpable swelling, and localized tenderness serves as the diagnostic beacon guiding us toward either the erosive chaos of rheumatoid arthritis, raw wear and tear pathology of osteoarthritis, or this initial meticulous focus on localized symptoms is indispensable for prompt intervention. Now, regarding the precise characteristics of these localized signs, we shift our attention to the physical examination. Swelling, particularly the symmetrical polyarthritis characteristic of elderly onset rheumatoid arthritis, EORA, often presents differently than the effusion seen in OA. The tenderness in EORA is typically periarticular and excruciatingly sensitive to even light pressure, a sensation patients too frequently dismiss as just part of getting old. Which, by the way, is a medical diagnosis roughly equivalent to diagnosing someone with the vapors, utterly useless and entirely prevalent in society's approach to geriatric complaints. In this discussion, we emphasize that the precise nature of the inflammation provides critical clues. OA often features hard, bony enlargement and pain exacerbated by activity, whereas EORA exhibits a more insidious, inflammatory pattern, sometimes presenting atypically with features resembling polymyalgia. Ignoring these localized signals, the hot, angry joint, the grinding sensation, the morning stiffness lasting over an hour, guarantees a trajectory toward functional decline. Studies consistently demonstrate that the chronic, localized pain experienced by older adults with unrecognized or poorly managed arthritis dramatically impacts their quality of life, leading to increased isolation, depression, and dependence. Differentiation between OO and RA, especially in the elderly, where EORA can present mysteriously, hinges significantly on the precise pattern of joint involvement. Monoarticular knee pain suggests OA. Bilateral wrist and MCP swelling strongly suggests inflammatory RA. These localized symptoms are not mere discomforts. They are blueprints of future disability that we are ethically mandated to alter. Therefore, when evaluating the elderly patient, our physical examination must systematically map these localized disturbances. We must inquire deeply about the duration of morning stiffness, the specific joints affected, small joints versus large joints, and the relationship between pain and activity versus rest. A swollen, persistently painful joint in a patient over 65 is never merely an expected consequence of longevity. It is a red flag demanding biochemical confirmation and therapeutic action. Recognizing and meticulously documenting these initial localized warning signs is the first indispensable step toward halting the progression of joint destruction and upholding that foundational dignity of mobility we promised. The true distinguishing feature of joint inflammation in the senior patient is not the pain itself, but the persistence of morning stiffness. A patient with typical osteoarthritis OA, often characterized by asymmetrical joint involvement and subchondral bone changes, experiences a gelling phenomenon, stiffness that melts away rapidly, usually within 30 minutes of movement. This is mechanical wear and tear, akin to an old hinge needing oil. Conversely, the elderly onset rheumatoid arthritis era patient reports stiffness that clings stubbornly, often lasting well over 60 minutes. This is the inflammatory red flag, signaling a systemic assault requiring swift disease-modifying intervention rather than mere symptomatic pain management. If the stiffness demands 2 cups of coffee, a soap opera, and a heated blanket before finally releasing its grip, we are almost certainly looking at EORA. In this discussion, we must acknowledge that EORA frequently defies the classic textbook patterns seen in younger patients, while typical rheumatoid arthritis targets small, symmetrical joints. EORA often starts in larger joints, resembling polymyalgia rheumatica, leading to detrimental diagnostic delay. Too many clinicians succumb to the pervasive, yet utterly bankrupt, notion that old age inherently mandates suffering. They wave away complaints of pain and protracted morning stiffness with a condescending shrug and the diagnosis of general aging, perhaps suggesting the patient take up knitting or move closer to the pharmacy. This diagnostic nihilism is scandalous. It allows progressive joint destruction, compromising not just comfort, but the essential quality of life and independence. The impact of chronic, uncontrolled inflammation on overall well-being in the elderly, contributing significantly to falls in fragility, is profound. The difference in symptoms reflects a fundamental divergence in pathophysiology. OA is primarily a mechanical failure, driven by cartilage degradation and altered bone signaling, often amenable to conservative management strategies that include improved nutrition. Flavonoids, for instance, show preclinical evidence of nutrigenomic activity in mitigating the localized inflammatory burden. EORA, however, involves a complex dysregulation of the immune system, characterized by elevated pro-inflammatory cytokines, initiating a destructive cascade that affects far more than the joints themselves. Consequently, clinical assessment of stiffness must be immediately followed by serological confirmation. Elevated rheumatoid factor and anticyclic citrullonated peptide anti-CCP antibodies, coupled with markers like ESR and CRP, provide the necessary empirical proof to justify aggressive targeted therapy aimed at stopping the systemic fire before irreversible bony erosion occurs. Failing to recognize prolonged morning stiffness as the critical signal delays the initiation of appropriate disease-modifying anti-rheumatic drugs, DMARDs, or biologics, pushing the patient toward unnecessary functional decline. Early, accurate diagnosis of EORA, distinct from the slow, mechanical creep of OA, is paramount for preserving mobility and preventing the severe limitations that dramatically erode quality of life in older adults. We are not merely treating painful joints. We are defending the patient's future capacity for self-care, autonomy, and dignified engagement with the world. Every hour of prolonged stiffness is a countdown to permanent damage, and our mission is to reset that clock through vigilance and timely intervention. The vigilance required in geriatric rheumatology is often tested by the chameleon nature of elderly-onset rheumatoid arthritis. Unlike the textbook presentation seen in younger patients, symmetrical small joint involvement, EORA frequently disguises itself. The insidious start often masks the severity, mimicking the common aches of osteoarthritis or the widespread stiffness of polymyalgia. This diagnostic overlap is perilous. When EORA strikes those over 60, the inflammatory aggression is compounded by pre-existing age-related decline, making the preservation of fundamental capacity, the ability to dress, cook, or simply walk unaided, our paramount concern. Early and accurate diagnosis is the first line of defense against rapid functional decline and the subsequent loss of autonomy that accompanies severe inflammatory disease. In this discussion, we must emphasize that EORA is rarely confined to the joints. Its hallmark often includes pronounced systemic symptoms that precede or accompany the arthritic pain, such as malaise, low-grade fever, and unintentional weight loss. The inflammation is a torrent, not a trickle, affecting overall metabolic health. The presentation itself may be atypical, monoarticular or asymmetrical initially, frequently targeting large joints, like the shoulders and knees, which often misdirects the unwary physician towards a purely mechanical diagnosis. It is fascinating how many patients initially dismissed with advice to just take Tylenol and slow down are later found to be harboring a severe autoimmune storm. Apparently, medical inertia believes that joint destruction is just the price of aging, like receiving spam calls for funeral plots. Distinguishing EORA from PMR remains a clinical tightrope walk. While PMR responds rapidly to low-dose corticosteroids, ERA demands far more sophisticated and aggressive immunomodulation. ERA is characterized by persistent synovitis and the potential for rapid bony erosion, directly threatening the patient's ability to maintain self-care. Failure to identify EORA leads swiftly to irreversible disability, trapping the patient within a cycle of dependence. This reduction in autonomy dramatically impacts their quality of life, transforming robust seniors into frail individuals, confined by pain and inability. The chronic inflammatory burden also feeds into conditions often associated with aging, demanding a systemic approach that recognizes the interconnectedness of musculoskeletal health and overall vitality. The primary treatment strategy, therefore, must be robust and timely, emphasizing the use of conventional and biological disease-modifying anti-rheumatic drugs, DMARDs, to halt the destructive process. We are moving beyond mere symptom management to target the underlying a necessary aggression given the rapid damage potential. Controlling the inflammatory cytokines effectively defends against not only joint erosion, but also the severe chronic fatigue, nutritional decline, and lowered mood that accompany uncontrolled systemic disease. Our therapeutic imperative is to secure sustained remission, ensuring that the patient retains the critical independence and dignity they deserve, allowing them to engage actively with the remaining years, rather than succumbing prematurely to preventable mechanical failure and chronic reliance on others. When that promised independence begins to slip away, when rising from a favorite chair becomes a 2-minute ordeal, or the distance from the bedroom to the kitchen shrinks daily, the alarm must sound immediately. Progressive mobility loss is not merely an inconvenience in older adults, it is a profound clinical symptom demanding urgent attention. Whether driven by the deep systemic inflammation characteristic of elderly onset, rheumatoid arthritis, which attacks the soft tissues and major joints like the shoulders and knees, or by the unyielding cartilage destruction found in advanced osteoarthritis, the endpoint is the same. Functional isolation. This rapid decline mandates a reassessment of the current treatment strategy, especially when it restricts essential activities of daily living ADLs, rendering the simplest self-care tasks monumental challenges. In this discussion, we must emphasize the urgency surrounding sudden changes. The challenge often lies in distinguishing what is purely mechanical OA from what is inflammatory EORA. EORA, often mimicking other conditions like polymyalgia, requires aggressive immunomodulation because the joint damage starts almost immediately and is irreversible. Many patients, sadly, wait too long, convinced that their acute inability to lift a kettle or dress themselves is simply a bad day or the inevitable march of age. This delay is tragically common. They might spend weeks attempting various home remedies, bless their hearts, like applying mustard plasters or consuming copious amounts of turmeric, convinced that nature's remedies will somehow override a T-cell mediated autoimmune cascade. When mobility loss accelerates, particularly if accompanied by fever, night sweats, or profound fatigue that anchors them to the sofa, general practice care must be superseded by urgent rheumatological referral. Neglecting progressive functional decline transforms a manageable chronic condition into a life-threatening crisis. The risk of injurious falls skyrockets when weakened muscles and painful, unstable joints compromise gait and balance. Furthermore, the ensuing immobilization dramatically degrades quality of life, leading to social withdrawal, dependence, and measurable cognitive decline. Recognizing these immediate threats drives our aggressive approach to treatment. For severe inflammatory disease, the targeted biological agents, such as TNF inhibitors or specialized DMARDs, are essential tools, not optional luxuries. For severe end-stage OA, the discussion shifts urgently toward surgical intervention. Our goal is to interrupt the cycle of pain, disuse, and deterioration before the patient requires long-term institutional care simply because they can no longer navigate their own bathroom. The crucial takeaway is empowerment. Patients and caregivers must be educated to recognize the specific thresholds that necessitate urgent contact. Inability to walk unaided across a room, inability to prepare a simple meal, or rapid swelling in previously stable joints. These are indicators that the inflammatory or mechanical forces are winning the war. We treat mobility not just as a physical capacity, but as the fundamental expression of continued personhood. When a patient can move, they can choose. When they are restricted, choices vanish. We fight cytokine storms and cartilage thinning with equal ferocity, ensuring that the critical window for intervention before permanent disability sets in is never missed, safeguarding the physical autonomy they have fought hard to maintain.